Welcome everyone to the ACPMP webinar. I see people are coming into the lobby, which is great. Pull up a cup of coffee, nice glass of iced tea, comfortable. We're just going to wait a couple minutes and let people come on in and get settled, but glad you're here. Again, welcome everyone to the ACPMP webinar. We'll be starting in just a minute or two, just giving people a chance to come on in, log in, and get through the lobby. Thank you. Okay, wonderful. We got a couple minutes past 7 Eastern. Let's go ahead and get started. Hello, everyone. My name is Deborah Shelton. I'm the Executive Director for the Appendix Cancer PNP Research Foundation, or ACPNP. We're very excited to welcome you all to our first of 2 August webinars in the ACPNP educational series. And tonight we're really excited to feature a presentation by Dr. Alissa Greenbaum. The title of her presentation is Quality of Life, Shared Decision Making and Decision Regret in Cytoreductive Surgery and HIPEC. So a very interesting, intriguing topic, I think, for all of us. By way of a brief introduction of Dr. Greenbaum, Dr. Alissa Greenbaum is an assistant professor of surgery at the University of New Mexico School of Medicine. She specializes in gastrointestinal and peritoneal surface malignancies. She is a program director of the University of New Mexico Peritoneal Surface Malignancy Program, which is the only cytoreductive surgery and hypothermic intraperitoneal chemotherapy, or HIPEC, program in the state. Dr. Greenbaum also serves as Associate Program Director for the General Surgery Residency at the University of New Mexico Health Sciences Center, focusing on resident wellness and surgical ergonomics initiatives. Her research includes large database research examining surgical outcomes in patients with gastrointestinal and peritoneal malignancies. She is proud to serve the diverse patient population of New Mexico and surrounding areas of East Texas and Western Arizona. And I think Dr. Greenbaum has a little bit more context that she wants to share by way of intro. But before I turn the wheel over to you, Dr. Greenbaum, Alissa, can you put up the brief housekeeping slide? Great. Yes, I should say that the ACPMP mission, for those of you that are new to ACPMP, our mission is twofold. One, we support and fund educational programs to keep us all current on the ever-changing kind of thinking to do with appendiceal cancer and to help increase awareness. And we also support and fund research to move research forward, find new treatments for appendiceal cancer with the hope of one day finding a cure. By way of very brief housekeeping, one, we will be taking questions live during Dr. Greenbaum's presentation. We're going to do that though through the Q&A function at the bottom of your screen. So if you have a question, you could type that in at any time, but please understand that the chat feature is disabled. Your questions should really come through the Q&A or we will not really be able to respond. Also, please know that we're fortunate. Dr. Greenbaum received a lot of questions as part of the registration process. So she is going to try to answer as many questions that she has gotten so far and that come through live as possible, time permitting, but probably will not be able to get to all of them. Your lines are muted, so if you are not aware of that, you should be. They are muted, and that's simply because with all the registrants, we want to really reduce background noise. This presentation is being recorded, and so it will be available on our website in a couple of weeks. But for those of you who may have folks that have registered that are not able to attend, have run into a conflict, no worries, they'll be able to access it immediately through the same Zoom link that they would have gotten as part of their registration. And last but not least, if you have any questions at all after this presentation, please feel free to reach out to me at deborah.s@acpmp.org. You can also always reach any of us at info@acpmp.org. Happy to answer any questions that you have about our educational series, any suggestions you have for topics, or anything at all. Always happy to chat. So with that, now I'm going to turn back to Dr. Greenbaum. Dr. Greenbaum, thanks so much for your time tonight, coming to talk to us.
Thank you, Deborah, so much for that introduction. Let me pull up my slides. Well, thank you again, everyone, for joining this evening. I am new to this collaboration with ACPMP, which I am just ecstatic about, and I will go further into the purpose of this talk and what I'm introducing, which is a collaborative effort in the form of a patient and caregiver survey that will be coming out to you all next month. But in leading up to that, I do want to talk about cytoreductive surgery and HIPEC, otherwise known as CRS HIPEC. And obviously, I'll be correlating this with appendix cancer and pseudomyxoma peritoni. The focus tonight is to talk about this concept, which is relatively new to oncology, but I think just incredibly important and has a lot of potential directions, which is this concept of decision regret, which I will get further into as we go along. I don't have any disclosures, and I want to emphasize that this presentation reflects my knowledge, my training, my current practice, and my opinions only. I want to thank Deborah Shelton and also Alissa for putting this together. My mentor, Dr. Richard Alexander, which I know many of you have probably heard of. He's just a giant in this field, and I was so lucky to train with him. My colleagues, Dr. Fay and Dr. Neer, and really all the people that I work with at UNM are just phenomenal colleagues. And then in my capacity as a new member on some national committees in terms of peritoneal surface, some of these names, again, a lot of you probably recognize. I appreciate their mentorship and sponsorship as I've started my career. And most importantly, I want to thank my patients for trusting me in this process and also for teaching me every day. I'm just going to give a very brief introduction into who I am, because again, I'm new to ACPMP, and again, I appreciate everyone being here. I am going to outline in about 10 minutes or so the basics of appendix cancer and pseudomyxoma, as well as CRS HIPEC, just so we have context going forward for when we're talking about decisions. and the decision to undergo this operation. What are we really talking about? And I encourage you, those of you who are patients and caregivers on this phone call, perhaps to start thinking about if any of this resonates with you and if there are any examples. And as we get to the Q&A at the end, if you're comfortable, I welcome you to mention some of these thoughts at the end. There is a body of literature about quality of life after cytoreductive surgery and HIPEC. However, this concept of decision regret is, again, relatively new in oncology and very, very new in surgery. Similarly, financial toxicity, I'll talk about what that means exactly, but this is a very important expanding area of knowledge in terms of cancer care and understanding the financial effects that it has on patients and, again, their families. And then I'm just so excited to introduce to you what this survey is actually going to look like, because this is pushing the field forward. Your participation in this survey will help us to help future patients and families. And then, of course, we'll get to the question and answer, both the pre-submitted questions and the live questions coming in. So very briefly, just to introduce who I am and how I got to this point to talk about appendix cancer. I did my medical school training at Oregon Health and Science in Portland, Oregon. That's where I'm from initially. I wanted to be a trauma surgeon and I loved the outdoors. So I came to Albuquerque, New Mexico, where there is outdoors and a lot of trauma surgery. However, my first month of residency, I fell in love with cancer patients and the process and all of my mentors. So I switched to surgical oncology. I did 2 years of research there as well. I did my surgical oncology training at Rutgers, and that's where I met Dr. Richard Alexander, who, again, completely helped to steer my life in this direction. And I, again, just fell in love with these patients and the problem solving that goes along with this very, very difficult diagnosis that is pseudomyxoma, and learning how to develop the clinical judgment and understanding of this rare disease. And then I was so ecstatic and excited that there was a position open. I really miss New Mexico. And I'll say just one slide about New Mexico. So again, you can understand my context. And I came back here as faculty in 2021. So as you noted, New Mexico is in the United States. As we say, it's not new and it's not Mexico. It's a mile high, just like Denver is. We're in the mountains. These are the sandias that overlook Albuquerque, where I live. And it's a large state, and there is a metropolis that is Albuquerque. The next biggest town is Santa Fe, but it's only 2 million people. There's a lot of rural areas, and so that's why I get referrals from even out of state people that maybe it's easier to come see me than, for example, Houston, Texas. And we're one of 5 minority majority states, which means a white non-Hispanic population is in the minority. And very notably, and a lot of the other work that I do is with our Native American population, which comprises 11% of our population. So we're known for our international balloon fiesta. People come from all over the world to participate in this. And our green chili, a lot of people think have healing powers, but really it's just delicious. And again, we're not Arizona, so we do have mountains, we have snow, and we have a lot of lavender. This is a lavender farm that is just down the road, basically, from our hospital. So our center is a comprehensive cancer center, which we're very proud of that designation. And again, as Deborah mentioned, this is the only HIPEC center in the state. And at the urging, again, of some of my mentors, I really think about it more as peritoneal surface malignancy, because not every single patient gets to a HIPEC necessarily, but they are evaluated and they are cared for with their stage 4 disease. I have a phenomenal operating room team. I get to train future surgeons. This is one of my fellows operating with a chief resident and a medical student. This is one of my junior residents that I'm taking through a HIPEC for the first time and talking about all the subtleties and everything that Dr. Alexander taught me. And just as a note, there are some operative photos. Some of them are a little bit graphic. So the first 10 minutes is where those photos are. If that is bothersome, maybe you can listen to my voice more like a podcast than a webinar. If not, I do think some of the pictures tell a lot of the story. So with, again, the basics, and I know a lot of you have done just a phenomenal amount of self-education and through ACPMP have learned about this. But just to recap some of the actual numbers. So as you know, this is a rare cancer. It gets grouped into colon and rectal cancer in pretty much all the trials, a lot of the research and papers, because it's so rare, only 2,000 to 4,000 cases a year. But as you'll note, when we say peritoneal, that's the abdominal cavity, the metastasis and spread to the peritoneum can be in up to 50% of patients. So just a huge number of patients undergo this process where their appendix is blocked by a tumor. And again, we'll get into what some of those could be, but that blockage causes the increased pressure in the appendix, and then ultimately it can perforate, otherwise known as rupture. And when it ruptures, this mucin, which again we'll talk about, is not exactly like mucus, but it's a component of mucus, but this very thick type of material comes out and spreads around the abdomen. And that's called pseudomyxoma peritonei. So when whether I'm talking to a patient or talking to my trainees, I think it's really helpful to separate appendix cancer and how we think about it into two main categories. One is what we call non-invasive disease. This does not mean that it's not aggressive. This means that the mucin and the tumors literally sit on the surfaces of the abdominal organs. And they include, again, terms you're probably familiar with, which is a low-grade neoplasm or a lamin and a high-grade, but these sit on the surfaces. Excuse me. The disease that can become invasive, and by that we mean it has the ability or the possibility of traveling through lymph nodes and going to distant organs, for example, the liver or the lungs. That's when we think about adenocarcinoma with this whole range, obviously signet ring. If you've heard of that or have had it, it's the most aggressive type within adenocarcinoma, as well as goblet cell. Neuroendocrine is considered an appendix cancer, and it can be invasive. It doesn't always translate into pseudomyxoma peritonei. So in terms of what it looks like on imaging, this is an image actually of one of my current patients. She had appendiceal adenocarcinoma with PMP, and she's actually undergone 2 cytoreductive surgery and HIPECs already. They were 3 years apart each, and I'm seeing her back now with recurrence of her disease. So if you have not seen a CT scan before, this is a cross section of someone's abdomen. This white part is the vertebra, the spine, and then the front part is where the belly button is. And looking inside the abdomen, these circles you can see are the intestine. It's basically a cross section. And what's around the intestine, this gray looking material, that is the mucin. And when you look at it from, this is looking now at the patient from the front. This is the liver in the right upper quadrant. This white down here is the pelvis. And the bones. So you can see, again, the intestines are just floating in this material, which extends all the way from the top of the abdomen down to the pelvis. In terms of what it actually looks like, this is also a patient of mine. And this is also, to me, an example of how, what a wide range of presentations there are with this rare disease. This patient had his appendix removed, allegedly, a decade before. A lot of times when an appendix is removed, it's for appendicitis. There's a lot of inflammation. Sometimes you can't see all the structures that you need to because things are very stuck together. So sometimes you have what's called a stump. So a piece of appendix left behind, left on the colon. And so this patient, this mucin was discovered at a hernia repair. He went to have a belly button umbilical hernia repaired. And they found this mucin type material, which is what is spilling out of what's left of his appendix, which is this short stump here. So again, just because someone, I mean, this is a rare presentation, but just because someone maybe had an appendectomy before doesn't mean necessarily they don't have a piece of appendix left behind that has now developed this problem. Again, so that was this kind of thinner mucin that we were able to remove completely and complete his HIPEC operation. But I also recently operated on a patient with the same diagnosis, so a low-grade appendiceal mucinous neoplasm, or a lamin. And as again, you probably heard this term at some point. The omentum is what we call an apron of fat that hangs off of the transverse colon, which goes across the belly. And it's normally this thin kind of fat that sits on the intestines, kind of floats around, may have some role in the immune system, but we can also very well live without it. But in this patient, his omentum had been completely replaced by this mucinous tumor, and it was a heavy 4-pound tumor that was sitting on his intestines. Again, we were able to remove it, but again, that's another example of what pseudomyxoma peritoni can actually look like. So getting into how we came about this operation that we now do, and is honestly the standard of care for pseudomyxoma peritoni from appendix cancer in select patients. So Dr. Sugarbaker developed this in the 90s. It was around before that, but he really expanded its use and started to apply it in gastrointestinal cancers. And so his rationale is that this is actually a treatable disease, that we can potentially remove the tumors, and this can translate into prolonged survival. We knew before the 90s and with PMP that if without treatment, there was no long-term survival, that this ultimately was a terminal diagnosis. And also with the fact that we have not been able to develop further therapies that, for example, go through the bloodstream, which we call systemic therapies, to treat this. And I'll talk about why that is, but this was the rationale for the surgery. So there's a very specific way that the fluid in the peritoneum, again, otherwise known as the abdominal cavity, moves around the abdomen and gets reabsorbed. So it's normal to have some fluid in your abdomen to keep your organs basically lubricated. But when the appendix ruptures or perforates, which is what this drawing is showing, and these cells of mucin leave the appendix and now are free within the abdomen, that flow of peritoneal fluid is now spreading the tumor cells to certain places. And this doesn't mean that this happens for every single patient. And for a lot of patients, it's more extensive than this. But the reason why a lot of times I see, and we see as HIPEC surgeons, a lot of disease by the right diaphragm is that that is a normal place where peritoneal fluid gets reabsorbed into the body and the bloodstream. It basically is a filter. Similarly, when you are standing up, tumor cells can fall by gravity into the pelvis. And so these are very common places where, again, PMP can have more volume because of this normal flow of fluid. So Sugarbaker, again, outlined the very basics of cytoreductive surgery and HIPEC. He said, if we do maximal surgery, as in we physically remove all the tumors, and that includes a peritonectomy, which means that we're actually stripping the peritoneal layer off of the abdominal cavity. I'll show you a picture of that. Or if the tumors are so embedded or stuck to the underlying organ that to remove the tumor, we may have to actually remove the organ. And then after we remove all of the disease that we can see, we then perform this peritoneal chemotherapy, which is heated. And the rationale for that, which has been shown in laboratory studies, human studies over and over, is that the heat actually increases the killing capacity of the chemo that we put in to kill cancer cells that are floating around in the abdomen. This is getting a little bit technical, but I just want to show what we as surgeons use to actually quantify how much disease a certain patient has in their abdomen. So this can be, there's a CT PCI we can evaluate, there's a laparoscopic PCI where we look with the camera, and in every single HIPEC operation that we do, a PCI should be listed because we're describing exactly what we saw and exactly what we took out. So this is 9 regions of the abdomen, and we grade it depending on how big the largest tumor in that area was. So for example, We talked about the right diaphragm, which would be region 1. Let's say you have a 5-centimeter tumor there. That would give you a score of 3. And then also the small intestine is broken up. So once you add all that up, the highest score you can have, which would be the most disease anyone could have, would be a score of 39, and the least would be 0. This will come into play when I talk a little bit about outcomes, but just think about this as a spectrum of what we call the burden of disease, how much tumor is actually in the abdomen. Excuse me. So this is a picture of a right diaphragm with the peritoneum on top of the muscle, diaphragm muscle, with tumor. And that's what this white appearing substance is. That's tumor. So as we start to strip away the peritoneum, which we can actually do, you'll see underneath the muscle is left behind. Sometimes there is some invasion and we have to take part of the diaphragm muscle, but a lot of times this is truly sitting on the surface. So this is what a peritonectomy looks like. This is a pretty dramatic photo, but what you're seeing is this pink thing here is the transverse colon. And remember the omentum we talked about. This is, again, an even larger tumor than the one my patient had. This is from Dr. Alexander's case. But I just want you to see what cytoreductive surgery means. So this is what we're starting with. This is a lot of tumor. And then when we remove the tumor, what's left, for example, this is now the stomach, which is completely clear and clean. And this is the transverse colon that we saw. And again, that tumor is gone. So that's what cytoreductive means. When we talk about what is our goal, obviously our goal is to remove all of the tumor. We want to get the abdomen completely clean, not 1 millimeter left behind. That is not always possible because what we're balancing is, when we're talking about taking out multiple organs, is the patient's function and the quality of life. So one example is there may be small, let's say 1 millimeter nodules all along the entire small intestine. We can't remove the entire small intestine. Nobody can live like that. But if we get it down to 2.5 millimeters, we still know that HIPEC will help because HIPEC can penetrate, the chemo can penetrate up to 2.5 millimeters of tumor. So 0 and 1 is considered we completely cytoreduced, and HIPEC is indicated. Now, we do use HIPEC in some cases where we still have to leave tumor behind. There are some really strong indications for doing that because, for example, if ascites and all that fluid buildup is causing a lot of problems for someone, a lot of discomfort, the HIPEC can actually help with ascites. So even when we can't always remove all the tumor, there may be still a role for HIPEC. I'm going to show a quick video. Hopefully this comes through. This is just showing us putting in the perfusion catheters. Obviously, this is an open operation with a large incision. The catheters coming above are inflow. That's where the chemo is coming in. And this catheter below is where the chemo is coming out. So it's what we call a circuit. It's a constant flow of heated chemotherapy. And there's actually the pump right there. And that was Dr. Alexander putting in some chemo. And then we do this agitation of the abdomen to get the heated chemotherapy to go into every crevice and on every single organ surface that we can. And believe it or not, we do that for 90 minutes in most cases. So what is this mucin and why is it so difficult and why are we talking about this hugely invasive operation to remove it? So mucin, again, is not exactly the same thing as mucus. Mucin is included in mucus, but it's a little bit different. The layman's term, or what you may have heard, is something called jelly belly. I definitely don't say that with my patients, but that is this problem. That is pseudomyxoma peritonei, if you've heard that before. The problem with mucin is that, and you can see there's somebody scooping this out of an abdomen with their hands. It doesn't have a blood supply. So when we talk about chemotherapy that goes through an IV or through the veins, chemotherapy has to get from the veins through the peritoneal surfaces into the abdomen and then penetrate this very thick gelatinous material, mucin. And historically, it doesn't work very well because it can't get there to kill those cancer cells. There's a lot of research being done about the differences in prognosis of if this mucin has a lot of cancer cells in it versus if it doesn't have cancer cells in it. And again, a lot of you may have seen this on your final pathology report, acellular mucin, and maybe your surgeon told you this is actually a better prognosis because it's just, there's less cancer cells floating around the abdomen. Either way, even if it's cellular, we know we can get good outcomes potentially with HIPEC and cytoreduction. And then in terms of the surgery, and again, as we go forward, when I start talking about, quote, the decision to have the surgery, there is such a wide range of possibilities. And a lot of times as a surgeon, I can prepare a patient for what I think we're going to need to do in that operation. But a lot of times you truly don't know what's involved until you get in there. The CT scan is notoriously underestimates the amount of involvement, especially on the small intestine. So I'm giving this example of, let's say this patient had appendiceal adenocarcinoma. It's an invasive disease. And for that reason, they said, well, we have to take out your right colon because we have to harvest all the lymph nodes. That's the standard of care for adenocarcinoma. But let's also say there was some mucin in the omentum and there was some mucin on the peritoneum in that right lower quadrant. So we go in, we do a right colon removal, we remove the omentum, and we do our HIPEC. That operation is still a major operation, but it is potentially less to recover from than something perhaps that involves the spleen. Maybe, you've had to have a splenectomy or part of the pancreas taken out to remove the tumor. Maybe we had to remove part of the stomach. And this is a total gastrectomy, which would be, this is a subtotal. So a little bit of stomach is left, but a lot of times, it's still a major operation. And so and for women, because of that gravity, because of the tumor cells falling into the pelvis, a lot of times you need your uterus and ovaries removed. Obviously, if someone's postmenopausal, that will have less effect than if they're premenopausal, and that takes some discussion ahead of time. But these are all possibilities to get that complete cytoreduction or remove all the tumors. And so this can be a very different recovery. This can be a very different set of complications that can happen. So again, with this wide range of possibility, the question is coming down to how do we help patients to make this decision? And I just want to start with what informed consent is, because, the regret part aside, we'll get into that, just informing a patient what the procedure, what they can expect from the procedure, and what we as surgeons think they need to know about their risk. And risk is statistics. Risk is their chances of something. It's not guaranteed that that will happen, but we have the ethical responsibility to tell our patients these things could happen. And so we go over the procedure, what we're recommending. We talk about alternatives, and I'll talk about, again, PMP presents a really difficult conundrum because there are not a lot of alternatives right now. I will answer in your questions some things that are coming down the line. But at this moment, like I said, systemic chemotherapy is not effective for these huge tumors. But we still need to talk about the alternatives, which one is to not do the surgery. And what does that mean for you and for your family member? The risks is a huge, huge thing we have to go over, and I will list some of those. And then, of course, we want to make sure that all of your questions are answered before you consent or agree to undergo this major operation. And it always makes me think of in medical school, which now is quite a while ago for me, but I remember at my graduation, and this is all across the country, there's some form of this. When you agree to be a doctor, you are taking an ethical pledge, and you may have heard this, to do no harm. So what does that mean? And we'll talk about risk. There is a possibility to do harm, but what is the risk exactly that we're talking about? This is a paper from Dr. Foster, published somewhat recently, looking at a national quality outcomes data set. And what he did was compared CRS HIPEC to other major cancer surgeries. So removing the liver, removing part of the pancreas, removing part of the esophagus. And is HIPEC really more risky than other major oncologic operations? And what he found from this set, which has some limitations, but overall in this country, when we look at needing to go back to the operating room for another operation because of a complication, getting an infection, dying in the hospital, this mortality means that somebody died within 30 days of their surgery. HIPEC had a 1.1% mortality, which when I look back at the first publications and the first trials about this, their mortality was up to 35%. It was actually a pretty deadly operation. With all of the interventions that we've done to improve outcomes, 1.1% is actually phenomenal, but it's not zero. It's not zero. And that means that someone, and actually 20 patients out of 18,000, did not survive 30 days after the operation. But when you compare it to, again, these other major operations, it's actually better or the same. Same thing with the amount of time that you're in the hospital. This is length of stay. Again, olden days in the papers that you'll read, people were in the hospital a month. That's even if things were going well. Now my length of stay is around 7 days, and this national data set said about 8 days. So thinking about how we're decreasing the risk, and these are things that I account for with my patients, and I know that there are national efforts going on for us all to have pretty standardized ways of taking care of patients, because it's not just helping my patient get strong for surgery. And sometimes we don't have that long. Sometimes I see someone, they have an invasive cancer, and we're trying to plan their operation, hopefully within the month. So a lot of that includes, I have my patients go for 30 minutes of walking a day, and it's phenomenal what a difference that makes. That's one thing we can do before surgery. We also have to talk about support, transportation. I have patients that live 4 hours from the hospital and maybe don't have a car. So we have to think about these things. And then in terms of our medications and decreasing infection, there's all sorts of things that we do to prevent that. Then the patient has their surgery. And then after surgery, our recovery is also very different than it used to be. We're getting patients up out of bed. Maybe you remember after you had a surgery, you were sitting in a chair the night after surgery. That never used to happen. We also are limiting the amount of opioids and otherwise known as narcotics that we give patients. There's so many other ways to control pain now. And I think that's a major reason why patients are getting out of the hospital sooner. That's all of that is aside from managing a complication, which again, as some of you may have experienced, can keep you in the hospital for longer and is really unforeseen. Once they get through all of that, then the question is, do you need systemic chemo? For adenocarcinoma, for example, you may need another 6 months of systemic chemo. Or you may be entering into what we call your survivorship, which means that you have had the surgery, we removed everything, and now we're keeping an eye on things to make sure it hasn't come back, which it can do. So again, getting closer to the crux of today, which is when we think about the risk and the benefit of this major operation, and this is again something I'd like you all to think about, but when I think about what I'm offering my patients, I want to give them the chance to live longer, and while they're living longer, to feel better. And there is a possibility sometimes of cure with this, where we do the cytoreduction and the PMP does not come back. That's not always possible, but you never know who those patients are going to be. When we talk about risks, there are many. We talked about the chance of death, even though it's such a low number, it's not zero. I have to talk about even my patient could get a urinary tract infection that needs treatment. That's not life-threatening. It might not keep them in the hospital longer, but it is a risk that's related to surgery. So I'm going to start. So now that you understand, and again, a lot of you have personally experienced this, so you understand it very much, but what we're talking about with cytoreductive surgery and HIPEC, I want to transition into what's been published specifically about quality of life. So this is the parameter that we have used in surgery to try to answer the question, is it worth it? We believe that we have given this person more time, that they're going to feel better, but is that actually true? Do our patients agree with us? And Dr. Moran, you might also recognize his name. He's a very high volume surgeon in the United Kingdom. who also was one of the main pioneers of this approach. And they did a survey that's 36 questions and for patients who have had this procedure. And what you're looking at in this figure is kind of an interesting one, so I'll orient you. The score is from 0, which is the smallest circle, and then 100 is the bigger circle. And then this physical component score is a kind of composite of some of these other aspects like pain, how people feel they're functioning in their social life, their emotional and mental state. And then there's a separate score for mental component. So when you look at the blue line, these are the scores that people started out with before the surgery. As we go to the purple dotted line, that means pre-discharge, as in they had the surgery, but they're really early in the recovery process. And you can see that, especially with social functioning and physical scores, they get worse, which again, may not be surprising. You're dealing with pain and recovery. Maybe your diet is not back to normal. You're not going out to dinner with your friends, or maybe wanting to see people like you would normally. But as you get to 6 months, which is the red dotted line, and then a year out, not only have the scores gone back to baseline, but you can see even with social functioning, it's better than baseline. So maybe that means, and again, this is my interpretation, that somebody had the surgery. Obviously, PMP is not comfortable, and maybe they're feeling better now, 6 months to 12 months after their surgery in terms of their symptoms. But really, and just so you know, this study included 25% appendix cancer and 20% had PMP. Just orienting again to what this population was, and this is pretty intuitive. So when we talked about that PCI, again, that means how much tumor somebody has. So PCI less than 12 is a lower amount, PCI 13 is more. So maybe not too surprising that their physical effects and quality of life was worse when they had more tumor to remove. And again, maybe that has to do with what we talked about, how many organs have to be removed and having a longer recovery. Same thing with patients who we could not remove all the tumor from, that they had worse quality of life scores, which I think also makes sense. Mentally, there was also a big difference for patients that had higher tumor burden. It was worse. And then with patients that had some tumor left behind, it was pretty similar up until a year out. And again, my interpretation is maybe at a year, their disease is progressing. That's my guess. So from this paper, and this is what I've quoted to my patients and what I was trained in, is that patients can expect an initial decline in their physical quality of life for 12 weeks. Within 6 months, I would expect their quality of life to return to baseline. And again, maybe even in some parameters would improve from before surgery. Patients that have less disease and then disease that was removed completely have better quality of life, which also makes sense. So really the conclusion is that we've said as surgeons, we're hearing from patients that this can be performed with acceptable quality of life outcomes. Yes, the first 3 months may be really difficult. And depending on your disease exactly, maybe we can't get you to perfection, but that it is acceptable, and it's worth it. Dr. Levine, I know that you guys have heard from in this organization multiple times, just a very high volume, very productive surgeon at Wake Forest, also did this questionnaire in for the United States. So he had, his group had 60% of the patients were appendix, and he looked at quality of life at 3 months, 6, 12, and 2 years after HIPEC. He also looked at overall survival, and won't go too much into this, but if you guys have not seen this Kaplan-Meier curve before, the higher line means better overall survival. And you can see that the appendix cancers actually have the best overall survival after HIPEC than other GI cancers and mesothelioma. This looked at the same thing as Dr. Moran's study, and the blue here is their baseline and the yellow is at 3 months. So similar to the UK study, in the United States, patients are saying at 3 months, my physical quality of life has dipped. This is also with a physical score. But then by a year and even 6 months, it starts to improve. So that is the story that we are saying to our patients and about what to expect. So we say it's worth it. If we can get you through this recovery, which we're getting really good at doing, it will be worth it to go through this major operation. I think the next step here is that exact question, not just what is your quality of life and it got better, but did you think that this operation was worth it? Do you agree with that statement? So I want to introduce this phrase, decision regret. It is not specific to surgery. And to be clear, this has not been explored in HIPEC patients before. And this has not been explored in appendix cancer. But the phrase came from this researcher in Ottawa. It's also known as the Ottawa Decision Regret Scale. And they note that regret is very different from some other negative emotions, for example, guilt or sadness, or even disappointment. The concept is really, if I knew then what I know now, would I have made the same choice? And obviously, this is a negative thing if you feel like you would have made a different choice if you have regret. They stem this from two different sources. One is that you now know that another outcome could have been better than the one that you chose. And the second is if you blame yourself and that you feel like you made the wrong choice, you made a poor choice. So why does this matter, again, when we talk about CRS HIPEC? Obviously, it's a negative emotion. It is about the surgery, which was a decision that had to be made. It can lead to compromised relationships potentially with your care providers. And these are your surgeons, your oncologists are people that you place a lot of trust in and you have long-term relationships with. They are potentially surveilling you or treating you for the rest of your life. It can cause some disruption with that. And also regret, and you may know from other forums, not just the surgery, can translate into depression, which we are just starting to scratch the surface of how mental health can affect our physical health. Because they are intimately tied together, as we'll see. On the upside, understanding regret really gives us information. And how can I potentially anticipate regret that a patient may have or avoid it while they're going through that decision-making process? And that is, again, we call it shared decision-making. That means between the patient and sometimes also their families are very involved in the decision and the surgeon, you're coming up with that decision together. It's a conversation. So this is what the measurement actually looks like. This is a validated scale that is now being used in many, many different areas of medicine. And as I'll show you, oncology and surgery. So the question or the statements that are made, and then you as the person taking the survey will either agree or not agree with that statement. So things like, it was the right decision. I agree with that. Or the choice did me a lot of harm. I agree with that. There was harm done. So this can, again, assess in a graded way how strongly that regret may be about that decision. So I just want to show some of and again, there are many studies done in, for example, breast surgery, which I'll talk about why that is. But in oncology, it's still a relatively new concept. So this is a study that came out of Spain, and they surveyed patients who had surgery and then needed surgery afterwards, which we call adjuvant chemotherapy, for 6 months. They also measured quality of life. And as you'll see in my upcoming slides, I believe that decision regret and quality of life are almost, they're connected. They affect each other. So what they found in their study was that over half the patients had no regret, about a third had some level, mild, and then 15% of patients had a very high level of regret. And what they found was that the more intense the regret, the higher the psychological distress and the worse their functional status just as people. And we were actually able to measure that. So they said from the study that maintaining psychological well-being is just crucial in patients in recovery, or perhaps still undergoing treatment. And we really need to focus on this and do individual interventions. And one suggestion was, for example, if one patient needs more clinic visits, maybe in 1 half-hour session, I can't understand someone's values and understand if I've answered all their questions. Maybe we need more visits. And usually I get more than one visit, but a lot of times it's maybe 2, maximum 3 before you have surgery with your surgeon. So one area this has been used in, which makes a lot of sense, is breast surgery. So in breast cancer, for example, you can have a mastectomy, which is a complete removal of the breast with reconstruction or not, or you can have a lumpectomy with radiation afterwards. And those 2 treatments it's a choice, because ultimately the outcomes from their cancer will be the same from those 2 different surgeries. So it really depends on the values and preferences of the patient. So in this study, they analyzed data from 1,500 women. And I was very surprised by this. So we think as surgeons, we want to do the least invasive thing, especially breast surgery has a lot of psychological components. So and I've seen some institutions where they kind of steer you towards the less invasive operation. The patients said that had the lowest regret scores were those that had a bilateral mastectomy. And that was compared to just having one breast removed versus the lumpectomy. Now, again, this does not mean we should be recommending bilateral mastectomy for everyone. This means the people that made that decision regretted it the least. So it may not always be what we think as surgeons people are going to say. And with these other cancers like breast, prostate, head and neck cancers, there are other treatment options, being hormonal therapy, radiation therapy, chemotherapy, immunotherapy, that we know can be effective and may even between 2 choices could have the same outcomes. With abdominal cancer, again, as many of you know, and how I outlined the problem with mucin, the problem with chemotherapy not working, there are less treatment options for this problem. And the alternatives that we're talking about, and again, we'll talk about some of them in our the questions you've submitted, there is developing research, but at this moment, these alternatives may not offer the same chance of cure or the same palliation that CRS HIPEC can offer. So I want to just highlight 2 studies, because there really are only 2 that I could find that pertain to abdominal cancers and surgery and decision regret. And these are all very new studies. So this one examined this surgery, which again seems so radical, but the surgery is for patients with the CDH1 mutation who have a 42% chance of developing diffuse gastric cancer. That is an extremely aggressive type of cancer that once you have it, can absolutely shorten your lifespan and be very difficult to treat. So the concept is, and what we recommend, these are national guidelines. If you have this mutation, even as a young person, we're recommending you have your entire stomach removed. And what this is showing is the reconstruction, which is taking out the stomach, attaching the small intestine to the esophagus. A lot of people can't believe you can live without your entire stomach. You absolutely can live without your stomach, but there are potentially life-changing consequences to that operation. So they gave that survey to these patients who'd had the surgery. And 43% of patients expressed regret about undergoing the operation. And maybe not surprisingly, it was correlated with having a complication after surgery. So people whose surgeries went very well didn't regret it as much. People who had a problem after surgery did. Also, patients who had their stomach removed and the pathologist looked at it and there was no cancer in that stomach expressed regret, because maybe there is that question. They're wondering, did I really need to have that operation? And again, our numbers are saying yes, but is that true for the patient? So their conclusion, and again, this paper just came out this year, is we should be individualizing our cancer care, and we need to improve our preoperative counseling and improve our decision-making process. Maybe if 43% of patients regret what we did to them, maybe, well, definitely we need to do a better job in our discussions. This is the second paper I wanted to show you, which is an amazing review. So really it was looking at what is prevalence means, how often is it for major abdominal and thoracic procedures, and then what is related to regret, how does this happen? And so again, they tied together quality of life and decision regret, that same scale. They looked at the complications and how the communication was with the surgeon. They had 157 patients, 20% were colorectal. They didn't list exactly appendix, but again, this hasn't been explored specifically in appendix cancer. Almost 2/3 of patients did not regret their operation. 1/3 did, and almost 10% had significant regret. And again, with complications, patients who had a complication were 5 times more likely to express regret, which I think, again, makes complete sense. So again, this is a really amazing analysis they were able to do, which is, I won't go into detail too much, but essentially what you're looking at is the weighting of how the decision-making was made. Did the patient feel like they were driving the decision, or was the surgeon driving the decision, or was it a shared decision? And so you can see in patients who had less regret, they felt like their decision was made by them. In people who did have regret, they felt like the decision was more driven by their physician and not as much shared and not as much by them. So when we're talking about the correlation between having regret and, for example, depression and anxiety, again, it makes sense. We know as a human being that those things are related. But when we talk about surgery, it's also true. So less anxiety and less depression in people who don't have regrets. Now, it may be a chicken or the egg, but that's something, again, I want to know more about. So patients with regret were 5 times more likely to have borderline or abnormal depression scores. So this paper concluded these are the factors that are associated with a patient having regret about their major operation. How the decision was made. Did they feel like they were driving that decision, or did they feel like their surgeon was? How did it go postoperatively? If they had a complication, how did we help them deal with that? And I'll say, as much as I care about my patients and pull in all the resources I can, I think we can do a lot better with the mental coping of complications. I mean, it's a huge area we have not invested, I think, enough resources in. And then, of course, quality of life is also tied in. So just to throw in 2 more concepts, I know that we're coming up on the hour. Financial toxicity could be a 2-hour-long talk in and of itself, but I just want to introduce what this term means, because to me, it also ties into a potential source of regret. So this means that someone had hardship, financial hardship, as a result of having cancer, as a result of having treatment. Otherwise, and there's a lot of different definitions, but these were my favorites that I picked out. So a monetary burden of paying for cancer care. This is directly related to your treatment. It's now considered another side effect. It's not just that the oxaliplatin gave you neuropathy, like what happened with your life savings. It's unanticipated and often unintended that it directly affects families and individuals. So in 2014, this paper noted that we spent almost $88 billion on cancer care, and $4 billion of that was directly out of patients' pockets. So this is a huge, huge topic that, again, we are just beginning to scratch the surface of. And what impact does this have, not just on our patients' quality of life, but their cancer care? And so this paper I thought was really interesting, and there are many in financial toxicity, but this asked these 3 questions. Did you take less medication because of the cost? Were you worried about your food and housing? How about clothing, transportation? So very basic things. And when they talked about cost with patients, this was more of a qualitative study, these were the themes that came out. And again, as you all know, who are patients and caregivers, this is a huge problem. The cost of care, the ability to afford it. People lose work, they lose income, and then all of the costs just not even related to the treatment. And so what they found is that the financial toxicity, when it's high, it translates into lower quality of life and these same patterns as regret with anxiety and depression. So I'm going to go through this a little bit quickly because I want to make sure we have enough time. But what this paper was saying is that obviously this, if you're not insured, this you have a much higher chance of having a devastating blow to your finances. So 9 out of 10 uninsured patients were at risk, and 1 out of 10 insured patients, which is still not small. 10% of patients could have catastrophic hit to their finances. In terms of caregiver burden, and again, this is, I could give an entire 2-hour or 1 week talk about caregivers, which some of you on this call may be. The patient, this is outlining kind of some of the sequence of things that can happen with caregivers. So the patient, your loved one, gets a diagnosis. Something can happen. Maybe you got diagnosed with appendicitis and you went in for an appendix surgery. Now you're told you have stage 4 cancer. Maybe you came in with a bowel obstruction. There are these instances that happen that they call health shocks, where all of a sudden you are aware that that this is happening. 90% of caregivers experience work disruptions. Again, not unexpected. A lot of times patients cannot drive themselves or do a lot of the care that's required at home. And even for caregivers, they can have this anxiety, depression, and isolation. And so the multiple steps and problems in cancer care can cause this ripple effect. And I don't want to get too down. I know it sounds depressing, but there's I think there's so much hope at the other end of this, but I do want to outline what the problem is that I'm looking to answer. So I made this chart because to me, quality of life, decision regret, and financial toxicity, again, are all tied together. They all affect each other, and we don't know which one came first, but I know that if we only look at quality of life and don't look at these other areas, we're not getting the full picture. So again, I want to very briefly introduce what this survey looks like that we will be sending you all. So tell your friends, tell people that you know that have been through this process. Again, the ACPMP is just a phenomenal foundation resource for this rare cancer, because we can work on this together. And what this will look like is an email that will go out to you, and I'll give some more details about that. But really what the survey is going to ask, it's quite a few questions, but it will take about 20-25 minutes to complete. We're going to ask, it's anonymous, so we will not have names, identifying information. We will have no idea who's answering this, and I hope that allows you to be as honest as possible. But we do get the basics of, for example, what was your diagnosis? Did you have the surgery? You can answer the survey if you didn't have surgery, because we're also curious about, or do you regret that you did not have the surgery? Do you have PMP and you decided not to have the surgery? But I assume most of you will have had it. Did you have more than one HIPEC? Did you seek a second opinion? Did you have a complication? And again, this is phrased for patients and families. This will not get into shop talk, but you know what your course has been. We'll ask you, were you in the hospital for longer than a month? Did you need, for example, IV nutrition? And the rest of it is these validated surveys. So this one comes from the FACT-C. It's very specifically asking about GI symptoms. And again, I'll also note this, but people that can answer it are more than 30 days after your surgery. Because we know that if you're filling out the survey and you're still in the hospital and you still have a nasogastric tube in, that's not the right time to fill this out. But a lot of people, as you know, can have some longer term GI side effects, including how you feel and how it's going managing an ostomy, which can a lot of people be something that we have to do, but it can be life-changing. So again, you grade this as to how are these symptoms affecting you? Not at all or very much so. The second one is 12 questions about financial toxicity. Same thing, where you are reading a statement and you either say, no, this doesn't apply to me, or this very much applies to me, and everything in between. Do you feel in control of your financial situation? Has your illness been a financial hardship to you and your family? And again, this is I did not write these. These are a validated survey asking these questions. Same with our quality of life. I'm going with a little bit different one. This was at the suggestion of a couple of my collaborators who are also introduced. These are 29 questions, which seem like a lot, but each of these sections have about 4 to 6 questions. And again, these are the areas we want to know about. Do you have pain? Are you sleeping well? Are you tired? And then there'll be 2 separate links. One will be for caregivers, and there's a specific 12-question scale for caregivers. And again, these are just some examples of questions. So have you felt stressed? Has your health suffered? Do you feel like you don't have enough time for yourself? Now, again, these sound bad, but maybe you're going to say, you know, I had all the resources I needed. We had a great support. Maybe our church was supporting us, our family, our friends, and I felt very supported. I'm not saying that you have to say that you're stressed. If you don't agree with these statements, you'll say, no, I don't feel this way. So I want to thank my collaborators who are at University of New Mexico with me, Dr. Sue, Dr. Ward, and Dr. Lambert. I know you recognize some of these faces. I appreciate their input on this process. We basically have the survey ready to go. We're building the link right now. Again, it'll be available for patients greater than 18 years with appendix cancer. I said has CRS HIPEC or more than one. Also, if you have not had surgery or you decided not to have it, and also 30 days since the procedure. So I am really looking forward to the question and answer session now. Thank you so much for your attention during this hour-long talk. I really want to know what you all think and feel about the surgery, and we look forward to hearing from you, and look out for an email. I'll say one more thing, Deborah, I know we're ready to go. So in terms of what are the results going to mean, I think there's 2 outcomes. We're going to either see that you guys say, I don't regret it. And that means that we're on the right track. It was worth it. And we are working on national efforts to standardize our care plans. If you say that it's not worth it, we have a lot of work to do in terms of, again, finances and resources. In terms of future directions, again, we are working on these national levels. And I think this is another piece of the puzzle that will be so important for how we care for patients with appendix cancer. Thank you very much.
Wow. Thank you, Dr. Greenbaum. That was tremendous. As you're talking, all I'm thinking about is, wow, maybe for surgical oncologists that do CRS HIPEC and treat appendix cancer, they should all first want to be trauma surgeons. If that's the magic sauce, I'm serious, with having your communication skills, compassion, you're reflecting the transparency, your willingness to kind of, I love the way you unpacked everything from kind of the bottom up and shared those slides and really talk to all of us like we're reasonable right people, and just having that sort of accessibility. So thank you very much. So now we do get into questions and answers. And we, as I said at the top of the program, we got a lot of questions during the registration process, which is very much appreciated. We've also got a few questions live. So Dr. Greenbaum, I don't know, would you like to start with maybe answering some of the pre-submits, and then we can try to get into some of the ones that we've got live? Or
absolutely.
Okay.
Yeah, and thank you to everyone there for submitting your questions. I won't be able to get to every single one, but I've also kind of grouped together some questions that, because there are themes. And so I did group together some of the questions. So if it's not your exact one, hopefully I will get you an answer. So I'm just going to start with the treatment questions, kind of the technical. Can success be achieved with a second HIPEC? This is something that I am working on disseminating the knowledge about, because there is some kind of rumor that maybe the second, third time can't be successful. Obviously, patient selection, and by that I mean, are we offering it to the right patient? But in patients that have been selected, Dr. Levine has actually showed that in a lot of his research through Wake Forest, that we absolutely can get successful outcomes from a second HIPEC. Now, again, setting expectations is huge, and everything we talked about is big, but there is data about that, especially for appendix cancer, because this is a slow growing, what we call indolent. It can develop over the course of years. For example, my patient, I'm probably doing a third HIPEC on. That HIPEC helped her for 3 years. She's in her 40s and was able to get on with her life, go back to work, and now it's come back. So I'm not going to answer what is the most number of HIPECs we should do, because that's debatable, but certainly a second and third have been described and could be an option. Someone asked, what does life after surgery but no HIPEC look like? So how I interpreted that was that a cytoreductive surgery was done where we mechanically remove the mucin, but we don't do the heated chemotherapy right after. There is some data about that from the 90s where we were doing what's called debulking. We just went in and tried to scoop out and remove as much as we could. We know that the chance of recurrence is much higher when we do that. And we also know that the addition of heated chemotherapy, once you've already undergone this major operation, does not necessarily increase your chance of complications any further. So especially for pseudomyxoma, pretty rare for someone to do a complete cytoreduction and then not do the actual chemo. And one of the benefits, I guess, they didn't talk about, the chemo is going into the abdominal cavity. They've studied this a lot as well. Some gets into your circulation, but not very much. And that's why we call it regional. We are treating the region of the abdomen and it's not getting into your circulation. I love this question. Any questions for dealing with scarring and abdominal adhesions? So I would say run-of-the-mill answer would be no, but I always try to keep my mind open and borrow from even other specialties. So I went to a conference this March about hernias, and they were talking about how physical therapists work with patients that have had major abdominal surgery. Again, this is they've had mesh put in, but as some of you may know, a HIPEC sometimes can be an extremely large incision, and it completely disrupts the abdominal wall or the musculature. And we tell you don't lift anything heavy for 12 weeks, and then you can get back, and maybe we refer you to physical therapy. I am referring more and more patients to physical therapy to do what they call scar work. Scars contract over time. And when it's on your abdomen, what happens is even people can kind of start to become contracted on the front part of their body. So you do not want to do this within 3 months of surgery. And you also should not do this without your surgeon's blessing. But going to physical therapy, for example, after 12 weeks, most of the time the surgeon says, yeah, physical therapy is great, do whatever you want. And they work on breaking up scar tissue so that it's not in this constant contraction state. And I've referred a few patients now, and I've had some good feedback about that. Nutrition and dietary recommendations. This is another one of my favorite subjects. What I tell my patients, diet and the interplay of nutrition with cancer is also just a huge topic. And my residents and fellows will attest to the fact that I talk about it a lot, and it does take time. This is not a conversation I can have in 2 minutes, but what I tell patients is, especially if you're on therapy, if you're on systemic chemotherapy, you do not want to be starting any kind of major drastic diet. For example, intermittent fasting. There's a lot of data about intermittent fasting, but in that extreme example where you're trying to starve cancer cells, that has got to be under the supervision of a doctor. And that's where these studies are being done. I hope in the future we'll have protocols and it'll make a lot more sense. But right now, do not do keto or intermittent fasting in the very extreme way. You know, if you want to skip breakfast, that's one thing, but without talking to your oncologist. Other than that, what I recommend is really pursuing health. What do we talk about in terms of a healthy diet? And it does not have to be complicated. The first thing I tell patients, see if you can cut out or decrease processed foods, which in the United States of America in 2023 is so challenging. That there's also a lot of research coming out about processed foods and cancer. So things that are in the produce section, things that come in their original form, you know, broccoli that grew out of the ground, a chicken breast, and helping it making it delicious. You know, it should, that's another really important part. I do not want a strict diet to you to be doing it because you're fearful. Food should be joyful, it's nourishment. And I think that's where, again, getting connected with a dietitian through your cancer center and learning more about it is just so key. I believe in fiber. I believe in trying to have as normal bowel movements as possible. And I know that's difficult after HIPEC sometimes. That takes a lot of trial and error. Titrating fiber, probiotics, there's mixed data about it. But I also, as long as you run it by your surgeon, there are 2 probiotics that are showing some research, some positive outcomes for people with diarrhea that have had GI surgery. One is lactobacillus and one is bifidobacterium. And again, as long as your surgeon says it's okay to try, really it has no downside other than maybe it won't work for you. But I have seen those work in patients. So that is actually in the NCCN guidelines in your survivorship to eat more plants, minimize red meat. But I will also say don't stress about your diet because stress is probably the worst thing for your health. So finding stress reduction techniques and finding a way to have a good relationship with food is really good. And another question was about post-op chronic diarrhea, which I addressed a little bit. Some things you can try again with the blessing of your surgeon. Another huge area, which I hope by the time that I retire, we've made some progress in, is about the microbiome. There are major changes that happen in the balance of our bacteria. We have pounds and pounds of bacteria in our body. That is a normal thing. They help us out a lot. But when the balance is thrown off by the stress of surgery or the antibiotics that you needed, we are just beginning to understand what effect that can have on bowel function and cancer. So right now we don't have a good way to measure that. But there are some things you can try. And obviously, I mean, staying hydrated when you have diarrhea is just so important. I will answer a couple more questions. So somebody said, why don't docs use the word cure even 5 years later, especially after a lamin? And that goes back to what I mentioned. Sometimes, especially with a low grade process, this can be very, very slow growing. And we actually do surveillance up to 10 years for that reason. I think the word cure, some people are more comfortable using it than others. I think if you have had no evidence of disease, no recurrence after 5 years, that is phenomenal. And each surveillance scan that goes by and you don't see any disease, that is great. If you had a lamin come back 10 years later, that just tells us that the disease is not as aggressive. And then maybe your surgeon would be talking to you about a repeat HIPEC at that point. Is there anything we can do to lower rate of recurrence? I will say right now, and I'm assuming that means with diet or medications or self-care, I would just focus on health and understand that if your disease comes back, that is not your fault. And this is a very complicated process that there's a ton of really, really smart people working on. And I'll get to that in the next question. But again, as much as you can to just work on stress and living your life, because that's why we're doing this, is for you to have quality of life and more time with your family and your job and whatever you enjoy doing. So last question is the research and development. So someone asked about, are we getting close to finding a way to remove the mucin without removing and resecting all these organs and taking away from quality of life? And then a second question was, what is the current thinking on Bromac? So Bromac, for those of you that haven't heard, is bromelain and acetylcysteine, which acetylcysteine is used to break up mucus, and bromelain is an enzyme. So this is very exciting because this has been the question since we started. Is there a way to break up the mucus from an enzymatic process and then remove it? Because right now, for example, interventional radiology, who we collaborate with all the time and puts drains in, they cannot help us with pseudomyxoma because they put a drain in and it's like trying to suck jello through a straw. Basically, you cannot drain it. So the protocol, which has been developed in Australia in phase 1 trials, so very early on in this process, to demonstrate safety, is that they put in the enzyme or the Bromac, and then they're able to, and then it liquefies and they're able to drain it. A few things, it's very exciting because I've never heard of anything like this before. I went to one of our conferences last year. This is not available in the United States. It has to go through many, many rounds of approval. And what I want to kind of temper expectations about, it still is palliative. And by that, I mean, it may help people feel better, but it's not removing all of the disease. So really that therapy is going to be, and I don't know how it's going to be used in the future. Maybe we'll use it in combination. Maybe we'll use it before we do a HIPEC. Or maybe it's only going to be in patients who are not candidates for HIPEC. And as with any other treatment that we do, there are risks. So, you know, as you can imagine, pouring an enzyme, which is its job is to break up tissue onto your intestines, is not a totally benign thing. So, I mean, and then you put a catheter in, you could have bleeding. So it's not for free, but it is a totally new development. And it is the first glimpse we've had about how can we manage mucin. And so I am excited about it. And I am looking out for the trial to be done in the US so that we can see if we can actually use it. In addition, and then the question was, what's changed? What's on the horizon in terms of research and treatment? I am very excited about peptide vaccines. I heard researchers at the Advanced Cancer Therapies Conference talk about this. It's just amazing. And also organoid research, which they're working on at Wake Forest as well as other places, which really is getting into personalized medicine, as in what chemo should we be using in your particular surgery. So basically they take your cell, if you haven't heard of it, they take your cells, they grow the cells in a lab, and then they test it with what temperature, how long, what kind of chemo, and then what killed the most cells. So I think those are the most exciting new developments in research. And I'd be happy to have Deborah look for some questions in the Q&A.
Great. Thank you for going through those pre-submits. So I'm looking, Dr. Greenbaum, you've got questions coming in. We've got about 10 minutes.
Okay.
Let me try to hit a couple that are probably pretty brief answers and get this done. So one question questions that are related from 2 different people. From a broader scale, what kinds of things would create the surgical oncologist's opinion that it would not be a good candidate for CRS HIPEC? And more specifically, and presumably this is an example of one of those conditions, we got a question about a frozen abdomen, like what causes that? You know, maybe you could explain briefly what that is, and you know,
Sure.
how does that come about? Like, how does
Yeah.
that condition arise?
So a frozen abdomen means that when we go in to do surgery, we find that the intestines, maybe the stomach, the colon, if it's still there, has formed basically, is just completely encased in scar and or tumor. And it's a terrible situation, because what it means, it's as if your intestines, which are these very soft, mobile organs, are encased in concrete. And we can't always tell that from a CT scan. Again, CT scans are notoriously difficult for evaluating small intestine. And you can't tell necessarily if the tumor is going to come right off, or if it's completely stuck. And so what frozen abdomen means is that as surgeons, we can't mobilize the intestine, and it's a very difficult problem. And I hope that answers your question. It's not very common, but when you get to those really high tumor burdens, or for example, you've had surgeries before, if you've had, even after one HIPEC, there's quite a bit of scar tissue. So I didn't mean to say that, oh yeah, you can have a second HIPEC. It is technically difficult because of adhesions and scar, but it is sometimes possible.
And it sounds like that's one circumstance that might equate to a patient not being a good surgical candidate. And I think also you're alluding to a high tumor burden. As you said during your presentation, the location of that tumor burden, if there's a lot of small bowel involvement, maybe it's the patient's health status. I don't know, I would assume. But are those other examples of where a patient would not be perhaps a good CRS HIPEC candidate?
Yes. And I think
Great.
one thing I didn't mention yet that's also coming down the line is something called PIPEC, which is pressurized intraperitoneal aerosolized. So that's being used in patients, for example, that we can't do a cytoreduction on, but we can do a minimally invasive approach to putting in chemotherapy, again, to maybe help control some of the effects in the ascites. Deborah, I'm wondering, I'm looking at Mike Wright's questions, and it is pertaining,
he's
and
got
then
a couple. Good. Yeah,
Susan, I
please.
want to address.
Absolutely.
So, Mike, you asked regarding decision regret and related support, is there an opportunity for surgical oncologists to partner with psychosocial oncology and palliative care? Absolutely. I got goosebumps when I read that, because I didn't mention that specifically, but that is where I think it is ideal for this to go. This is not necessarily that the surgeon in that moment can explore every single one of a patient and family values, because sometimes I think it's just too much to process. You know, patients may not even know what they're feeling until after they leave the surgeon's office. And so I think partnering, and I love that psychosocial oncology. I actually heard of a gastrointestinal psychiatrist the other day. So there are these subspecialties that are coming up that I think are just going to be so important for us to give complete care. And then, is there a correlation between decision regret and indicators PCI? I really want to know that. And again, this survey is the initial opening to this question. I think there are many other studies. I don't ask about PCI in the survey because I wouldn't expect a patient to necessarily know their PCI. But from some of the other indicators, maybe we can get an idea about their disease burden. But you're absolutely right. That is a fantastic research question. And then, do we have time for one more, Deborah?
Yeah, I hope so. I hope you can get to a couple more of the live ones, especially the pretty factual ones. Yeah.
I do want to get to Susan's question, because she said, I don't see correlating bilateral mastectomy with the least regret and removing internal organs. It doesn't correlate at all. And I want to support you in that comment. I brought that up as an example of these are the only studies that have been published in this arena with decision regret. Again, there's been nothing published about pseudomyxoma peritoni, HIPEC, and decision regret. So I'm saying it's an easier question to ask, I think, again, when you have these two surgical options. But again, in patients that are on this call where they don't have these options, what is the regret? So I completely agree with you that they don't correlate. And that's why we want to ask you all this question. Deborah, do you want to pick out another one or two that?
Yeah, can you, because we still have 4 minutes, so let's do it. Can you just briefly explain what extracellular mucin means? Somebody had that on their path report and are asking, what does that term mean? Extracellular mucin.
I agree it's a little bit of a confusing term. I think part of why this disease is so complicated is that it's taken us a really long time to have terminology on the pathology report that we all agree on. And I think it's been, once you get to, for example, an NCI designated center or a major institution that does a lot of this, and the pathologists know what language, and that's the same language that the surgeons use and the same language the oncologists use, it's much easier, but it does take some effort to all get on the same page. I don't know, I'd have to look at the rest of the report. I know with extra appendiceal mucin, what they're trying to say is that the mucin is not contained within the appendix, and there's some concern that it's gotten outside of the appendix. I don't know how to interpret the cells, because again, usually cells are in the mucin, or mucin is actually in the specimen that you can see. But yeah, I would, if you're still confused, your surgeon can, I clarify terminology with my pathologist all the time. Open communication. I send him an email, I give him a phone call and say, what did you mean by this? And they will tell me.
Yeah. And then on the imaging, I know in your presentation, you had commented that it often scans can underrepresent disease, especially on the small bowel, but somebody was asking about your thoughts on what the best imaging modality is, what would be the most effective. Is that a CT? Is that an MRI? Is that a scan? Something else we hear so many different things about.
Oh, yes.
Do you have an opinion?
Yeah, at this point, CT scan is still really the best test that we have. A CT scan now is, again, much better than it was even 10, 15 years ago. But the problem with CT scan is that we cannot see tumors that are under 5 millimeters and sometimes under a centimeter. So no matter how good our CT is, a lot of time that's why, is because the cuts of the CT scan can't capture 1 to 5 millimeter disease. MRI is also an option. That is also an approved way to look at the peritoneum. And that is an area of study as well. Is an MRI even better than a CT in terms of looking at the actual peritoneal lining itself? I would say as a surgeon, I use CT for surgical planning, because that shows me, again, your surgeon will be looking at the scans themselves. It's not just they're reading the radiology report. So when I'm doing surgical planning, I like CTs. But an MRI is more expensive. It takes longer. The benefit is that there's no radiation. I know a patient who can't get IV contrast because she has an anaphylactic reaction. So we do MRIs instead of CT. So really at this point, I wish our images will get better at some point, because they just continue to get better and better. But there is no better test than a CT and perhaps an MRI at this point. But either one would be fine.
Great. And then I know we're out of time, so before we let you go, one last question, as it came in pretty early in the Q&A lives. How far apart, you had mentioned that in patients, a second CRS HIPEC could make a lot of sense, could be very effective, possibly a third. How far apart between a second or third CRS HIPEC would you recommend? So there's a recurrence, somebody's had a second, there's a recurrence, now they're thinking about a third. Is there an amount of time in between those two CRS HIPECs that's recommended?
Yeah, I think, so my cutoff usually is a year. And I learned that from Dr. Alexander, who's taken care of a lot more patients than I have. And then I've also seen that borne out in the literature. You know, if you have it at 11 months, is that wrong? No. If you have it at 13. So, but it's really, the concept is that if, for example, if your disease came back in 6 months, that as opposed to that scenario we're talking about where it comes back at 10 years, that's telling us that that person's disease may be more aggressive. And we really want to, and as we talked about, cytoreductive surgery and HIPEC is a big surgery to recover from. So we want to make sure if it comes back at 6 months, there is concern that it could come back again. And so we really try to, one, see what happens over the course of that year, and two, you know, give you as much time, because you cannot have the surgery every 6 months. So we have to be very selective about the timing. And so usually, again, from what I've read and learned, a year more or less is the cutoff.
Great. Well, we are a little bit over. I still see questions coming in. I'm sorry that we couldn't get all of them. There is a question about goblet cell, and I would just say that as Dr. Greenbaum mentioned, pathology with this disease is very, very tricky. There's a lot of discordance even among the pathologists. But at our annual symposium in November, we'll be having a pretty extensive presentation by a pathologist who will be covering goblet cell. I know that can be a tricky. Dr. Greenbaum, can you talk briefly about goblet cell? But I don't know if you had any specifics. Otherwise, I think maybe, I mean, we're a little bit over.
Yeah.
So
yeah, it's a more aggressive type, but we still offer the same treatment. And we do have, again, the Chicago consensus guidelines are national guidelines that guide us. There's a specific chart dedicated to that. And it's meant mostly for providers, but if you're interested, that is what a lot of providers follow, is that those guidelines. And again, Dr. Turaga is working on an updated new set of guidelines that I hope will come out relatively soon. And there is some sections dedicated to goblet cell as well.
And I will also, thank you. I will also say that ACPMP has just launched its next RFP, request for research proposals, to get us thinking on research grants. ACPMP is going to be issuing at least 2,000 research grants. Why I mention this, though, for the person that asked about goblet cell, is in that request for proposals, we have specifically expressed an interest in research directed at goblet cell. So but this is great. Dr. Greenbaum, you are phenomenal. I think we're going to have you back. You ticked off several other topics that I think would be very, very interesting. So this is great. Everybody that's attended with all your good questions, thank you so much. I'm sorry that we didn't have time to get to all of them, but I hope that you got something out of this. I certainly did. I hope everyone else did. Dr. Greenbaum, thank you again, and hopefully we'll have you back.
Thank you so much. I would love to come back, and I appreciate everyone's attendance and being invited. Thank you.
Right. Okay. All right. Well, have a good afternoon. Good night, everyone.